this work because I've got to do it several times, I'm afraid. I'm Fiona, and I'm an audiologist. Oh, yeah? There's always one. See me afterwards. I can sort that out for you. So, as a part-time researcher, I have a clinical hat and an academic hat. No, really. I have a clinical hat. We don't really wear these, but perhaps we should. And an academic hat. I toyed with the idea of a mortarboard, but looking around the campus, this seemed to be more adequate for day wear. So I'm looking at adherence to therapy in the context of long-term conditions. And when I'm talking about adherence, I'm not talking about Velcro or denture fixative, nor am I talking about getting people over whom you might have an illusion of power to do what you think they should. That's called a university education. I'm using hearing loss as an example of a long-term condition because I'm an audiologist and because we have a problem with adherence in audiology. I spend my time clinically fitting people with hearing aids, and it would be nice if people wore them a bit more. There are thought to be 5 factors that impact on adherence. Firstly, patient-related factors like motivation and personality. So if somebody comes into your department and says, "My students say that I don't always hear them very well, but that's because my mind is on higher things. It's not because I can't hear them." You know that you're onto a pretty sticky wicket where selling a hearing aid is concerned. Secondly, there are condition-related factors. So hearing loss creeps up on you slowly, and it's quite easy to blame the fact that you can't hear on the youth of today, or the fact that they don't enunciate properly on the news anymore. There are therapy-related factors. Don't tell anyone, but hearing aids are a bit rubbish. And they don't really replicate normal hearing, so that puts a few people off. Then there are social and economic factors. If you're not lucky enough to live somewhere with a National Health Service, you're going to have to stump up the £2,000 to pay for your hearing aid, and that might make you have a few second thoughts. And then there are healthcare system factors, and that's my bit. So I'm interested in the changes that you can make in the healthcare system to promote adherence to therapy. Clinicians want their patients to do what they're told, if they know what's good for them. And we actually know the types of interactions between patients and clinicians that promote adherence. I'm interested in what makes clinicians adhere to those sorts of interactions. So I'm interested, as a researcher, in what makes clinicians do as they're told, if they know what's good for them. So, in terms of promoting adherence, we know that shared decision-making really helps. Unfortunately, we're not very good at that in healthcare. Most of us come into healthcare because we want to help people, and we're going to help them whether they damn well want to be helped or not. So shared decision-making requires some behaviour change on the part of the clinician, so that they can change their behaviour to help their patients change their behaviour. And I thought I'd illustrate this for you with a short clinical vignette. So pleased to get the word vignette. This is how a first audiology appointment might work out. So I've tested your hearing and you have a hearing loss, and so I'm going to fit you with a hearing aid. Okay. My patients don't wear hats. It turns out, surprise, surprise, that some patients say okay, take the hearing aid, but don't wear it. So a researcher comes in and says, "You need to be more collaborative in your approach because we think it will promote patient adherence." Okay. Well, blow me down. It turns out that some clinicians will say okay, listen to the advice, and not use it. No shit. It beats me how there's a PhD in this and it's not written on the back of an envelope. Luckily, there is an easier way to achieve success, at least academically. In my very thorough, detailed, yet concise literature review, sadly my supervisor's gone home before he heard that, I've been looking at large-scale clinical trials of different interventions. And what's very clear is it's important to have a good name for your trial. So I've been looking at some examples. So from the arena of public health, we have... Sorry, I don't do PowerPoint presentations, I've got it on paper. The practical, robust implementation and sustainability model, a prism through which to view your quality improvement efforts. WISE, the whole systems informing self-management engagement, a very wise approach. It's all the fault of NICE. You note that it's not called the National Association for Specialist Treatment, Information and Education. Much better to be nice than nasty. From my own context, hearing healthcare, we have the hearing aid evaluation after oral rehabilitation, individual versus group trial. I'm not making this up. Can you see what they've done there? And I kid you not, from our American colleagues, the screening for auditory impairment, what hearing assessment test, or say what? Only in America. I'm guessing that in the UK this would be the, I beg your pardon. It turns out that having a sexy acronym for your trial can earn you nearly 3 times the citation rate of one published without a cool name. So, to ensure success with my academic hat on, I am following the lead of the Sexual Health Advancement Group, who are conducting the dysfunction of reproductive organs in older people. And I'm going with the hearing aid rehabilitation delivery options negotiation trial. Thank you very much.